Hello, everybody, and welcome to this webinar offered by Hands-On Seminars. I am Dimitrios Kostopoulos, and I will be presenting today's webinar. Uh, Probably some people will be watching this webinar recorded at some time in the future, but for those of you who are watching this webinar today, live, then you know that if you are somewhere in the northeastern part of the United States, as we are, I'm in New York, the weather is absolutely horrible. We have lots of rain and floods, and as you can see, I decided to be very casual today. So we're going to spend about an hour and a few minutes to discuss tonight some of the areas in regards to lumbar spine pathology. And from your feedback from previous webinars, we will make sure to take into account some of your suggestions and some of the challenges that you have had in our previous webinars. So thank you for your patience as we are becoming more familiar with the new technology, the webinar technology. Again, this presentation was developed by myself and my business associate, Mr. Rizopoulos. And for those of you, actually, let me ask you, how many of you may have taken a course in the past with Hands-On Seminars? You can just vote by clicking if you have taken a course previously with Hands-On Seminars or not. So I will give you just a couple of more moments to vote. I have almost everybody participated, and okay, I will close the poll. And as you can see, 63% of you have taken at some point courses with Hands-On Seminars, and about 13 of you have never taken a course with us, and 25% of you would plan to take some course with us in the future. So back to our topic. I would just real quick to mention, I would like to mention real quick the difference of Hands-On Seminars as opposed to other manual therapy organizations. First of all, Hands-On Seminars teaches exclusively manual therapy courses. And one of the things that we realized when myself and my business associate, Mr. Rizopoulos, realized when we first started teaching was that many courses out there teach in a non-clinical principle. So in other words, you may teach about a specific manual therapy approach, but you may not utilize a clinically oriented method. From the clinic, from our clinical experience, we realized early on that one manual therapy approach cannot be the answer to all patient musculoskeletal problems. In the past, we took many courses with various other manual therapy organizations, and the one thing that we realized was that you cannot apply successfully McKenzie to every single individual. McKenzie works better in some problems, but not so well in other problems. You cannot apply Maitland to every single patient and expect to have a positive outcome. So in the clinic, we early on realized that we must utilize a comprehensive model of manual therapy, a comprehensive model that includes a vast variety of manual therapy approaches that we then transferred those approaches into the classroom with the continuing education courses we teach. So essentially, we provide to our course participants a toolkit of a variety of manual therapy approaches so that they can select the most clinically effective, the most efficient, and the most evidence-based manual therapy approach for the specific problem of the patient. So at this point in our courses, we integrate the principles of myofascial trigger point therapy, muscle energy technique, strain counter strain, mobilization and manipulation, neural mobilization, proprioceptive training, and stabilization. So tonight, I will be discussing the principles of lumbar spine pathology from the viewpoint of neural mobilization, the viewpoint of mobilization and manipulation, and because yesterday when I was discussing cervical spine pathology, we had a small problem with the computer, and the part about strain counter strain was not very well presented because you could not see the slides. I will do that today. I know that both my friends Rick Schwartz and Ann Simmons, they are watching tonight, and they made sure to bring it to my attention that last night we had that type of malfunction. So I hope I will redeem myself tonight. Okay, so let's move on then, and I will first of all ask you a quick question, whether you currently utilize manual therapy. How many of you currently utilize manual therapy? Real quick answer from everybody as I'm sipping my tea. Okay, this is fantastic, because basically all of you are utilizing to some extent manual therapy. Some of you believe that you need to learn more about it. I happen to vote with the 27% of the people that I do utilize manual therapy, but I definitely need to learn more myself about it. So a few words about the epidemiology of lumbar spine pathology. 7 million people stay out of work every year because of a low back problem. And 63% of the work sickness, it is because pathology of the lumbar spine. What has been blamed is poor posture, lack of flexibility, muscle tightness, excessive lumbar flexion versus extension, and of course excessive lifting. I have a slide that compares the vertebra of the cervical, thoracic, and lumbar spines, and definitely you can see here that the spinous process of the lumbar vertebra is point straight. The transverse processes are very prominent, and of course the body is very large, as well as the spinal foramen. Obviously, the intervertebral disc that plays a very important role in the lumbar spine, and I see that some people are already raising some questions. Actually, one of the participants thanks us for discussing tonight again strain counter strain. Okay, that's great. But the intervertebral disc is very important, and not only because it forms the secondary cartilaginous joints between two vertebrae, but it becomes the culprit for many different types of pathologies, such as a herniated disc. A fourth of the length of the vertebral column is made up of the intervertebral disc. It allows movement, it becomes a shock absorber, and also what is very interesting that I'm depicting in this slide is that the annulus fibrosus, the fibers of the annulus fibrosus, as you can clearly observe here, are arranged in a cross bridge formation. As you can see here, we have fibers that are crossing with each other there and there. Now, why do you think the fibers of the annulus fibrosus have this cross bridge pattern? Well, the reason is that by creating this cross bridge pattern, you are able to increase the tensile forces that the annulus fibrosus can withstand. The nucleus pulposus with the annulus fibrosus around it, they work as a closed hydraulic system. So think about like a balloon. If you have a balloon and you apply a force on one part of the balloon, the resistance, the opposite force in other words, that is applied against your finger from the inner part of the balloon is evenly distributed through the entire surface of that balloon, the entire inner surface of that balloon. And this is one of the properties that we observe also in the complex of the nucleus pulposus and annulus fibrosus. And this is a good thing because this provides a protective mechanism for the nucleus to be maintained in a protective case. So very important components are the anterior and posterior longitudinal ligaments. Looking at the anterior longitudinal ligament, it's very important that it runs from the skull to the sacrum, and as it descends, it widens and it maintains, of course, joint stability. We will contradict that with the posterior longitudinal ligament. The posterior longitudinal ligament, as it comes from the cervical spine to the lumbar spine, it narrows. And this becomes a very, very important feature of lumbar spine pathology, because if you think about it, the vast majority, would I say 99.9% of lumbar herniations, they occur posterior or posterolaterally, and of course that can be also explained by the lack of the posterolateral support that is not being provided by the posterior longitudinal ligament, because as you can see here, as it descends into the lumbar spine, it becomes more narrow. Yesterday, I briefly mentioned about the various postural syndromes as they were described by Yanda. In all spinal pathology, to a larger or smaller degree, we will end up having some muscle imbalances. Muscle imbalances can be the result of myofascial trigger points, can be the result of abnormal muscle inhibition, can be the result of abnormal muscle excitation, can be the result of bad posture. And obviously, if in a specific area, the spine in this case, I have a muscle imbalance, in other words, muscles, a set of muscles that are very, very inhibited and weak, and another set of muscles that are into an excitation pattern where there is hypertonicity, I end up having a muscle imbalance that will lead to postural imbalances. Those are the forward neck syndrome, the upper cross syndrome, the lower cross syndrome, and the layer syndrome. Tonight I will discuss the lower cross syndrome and the layer syndrome. So the lower cross syndrome will include a tight and short iliopsoas and rectus femoris muscles, in other words, the hip flexors, tight and short tensor fascia lata and adductors of the hip, as well as tight erector spinae, while at the same time we're going to have weakness of the abdominals and the gluteal musculature. So this way, by maintaining tightness in the psoas and the erectors, the body tries to stabilize the neutrality, tries to stabilize the pelvis, tries to create a neutrality of the pelvis. So this is a lower cross syndrome. And this can cause a lot of problems unless we treat it. We're going to have an anterior pelvic tilt with exacerbated lumbar lordosis, as you can see here, excess stress on L5-S1 with pain and irritation. The quadratus lumborum also can get involved. It will become very tight, while the gluteals will be weakened and inhibited. And this excessive stress, the lumbar spine, can start causing also some lumbar instability. And finally, we have what is called the layer syndrome, or another name for the layer syndrome is stratification syndrome, where we have a combination of the upper cross syndrome and the lower cross syndrome, where we're going to have areas of hypertrophy and areas of weakness. So that is the layer syndrome. And these syndromes, we see them very, very frequently in patients. Now, the first topic, as I said, that I will be discussing tonight is the topic of neural mobilization. And definitely I would like to ask all of you if you are currently utilizing neuromobilization techniques in your practice. We see here a few more people need to vote. Okay, I'm going to close this. And what we see is that the familiarity of neuromobilization techniques in the subject is a little less compared to some of the more soft tissue techniques like trigger point therapy or muscle energy technique. Only 27% of the people are utilizing neuromobilization, 36% do not, and 36% also do, but they would like to learn more about it. So let's discuss a few principles of neural mobilization utilizing a clinical case. So this is a 66-year-old female. She's obese, and she presents with numbness in the left lateral thigh. So if I try to draw the area of numbness, the area of numbness is in the left lateral thigh. There you go. This is the area of numbness. I want you also to notice that there is a leg length discrepancy of the left leg, and pretty much all other testing I'm saying here is unremarkable. So the question is, what is the condition that can cause numbness, egg-shaped numbness on the lateral thigh? Anybody has a guess? Yes, some of you are screaming It is meralgia paresthetica, and it is correct. It is meralgia paresthetica. In other words, entrapment of the lateral femoral cutaneous nerve. And it's interesting here to see that the knee is slightly flexed. The left knee is slightly flexed. So the question being, what can cause meralgia paresthetica? Well, there are many reasons that can cause meralgia paresthetica. One of them is the fact that the nerve, the cutaneous nerve that innervates the lateral aspect of the thigh, which is called lateral femoral cutaneous nerve, becomes very superficial at the area of the ASIS. So sometimes people who wear very tight clothes or they put their belt very tight, they may develop meralgia paresthetica by the rubbing effect of the belt onto the superficial area of the nerve. Another set of population that we see the phenomenon of meralgia paresthetica are construction workers. If you remember, construction workers wear these, they have these tool belts. They have belts where they hang the different tools around them, construction tools, and because of the weight, the heavy weight of these belts, again, you may have this rubbing effect against the lateral femoral cutaneous nerve. But in this case, we have something else. Actually, where you can get a hint about this case is the fact that we also have a left leg length discrepancy. We have a shorter left leg, as well as we have a knee that is slightly bent. So I know that some of you are thinking exactly the same thing that I am thinking, which is the fact that the iliopsoas muscle, can perhaps cause that entrapment of the lateral femoral cutaneous nerve, as well as causing the leg length discrepancy with the hip flexion that produces a knee flexion also. This is what happens with this specific patient. You see, I'm going to show you a little, I have some props here for you. So if we consider that this is the iliopsoas muscle and this is the inguinal ligament, this is the lateral femoral cutaneous nerve. So it will be passing between the two. So what will happen is that if you have an iliopsoas muscle that has a certain length, when the iliopsoas is myofascially involved or for whatever reason becomes very tight, then the diameter of the muscle will increase and it will start rubbing the nerve between the psoas and the inguinal ligament. So that can be one of the potential causes for this meralgia paresthetica. Now, obviously, if I have a muscle problem, I need to use some muscle type of technique. So I could use muscle energy technique, I could use strain counter strain, I could use trigger point therapy. But in this case, just because we want to introduce the principle of neural mobilization, neurofascial mobilization, this is exactly what I am going to talk to you about. This was just a picture of the psoas again, but I'm going to bring up the concepts of neuromobilization. So, the nervous system, central and peripheral nervous system, function as a continuum, and the area, the fascial connection between the central and peripheral nervous systems is the area of the dural sleeve. The nervous system is designed to accommodate movement. Some examples is that the spinal canal is 7 to 9 centimeters longer in flexion than in extension. And most of the change happens in the cervical and the lumbar spines. Also, let's think of the median and the ulnar nerves. If I go like, one second, if I go like this, my median nerve is more elongated while my ulnar nerve is more shortened. The opposite happens right now, where my median nerve is more shortened and my ulnar nerve is more elongated. So the nervous system is indeed designed to accommodate changes in length. You can see here the dura, the arachnoid, and the pia, which are the membranes that are protecting the brain, part of the central nervous system. And in the peripheral nervous system, it will be the epineurium, the perineurium, and the endoneuriums that will provide protection to the neural tissue. Now here, this is very important. This is what you need to understand. The nervous system, the nervous tissue, has three important mechanical functions. Those are tension, nerve sliding and gliding, and compression. Now, what is important for you to understand is that all these three functions are physiological functions, as long as they are not happening for a prolonged period of time. What is tension? Well, tension develops in the various movements, body movements of closing or opening. And during these movements, tension will occur into the neural tissue, tension that will be accommodated by the neural tissue and protected. The perineurium will protect the nerve from those tensile forces, which actually can go up to 20% of strain before we see an actual failure of the neural tissue. So tension is something normal that happens in the neural tissue. Now, what happens with tension and how the nervous system can accommodate tension is the fact that the nerve fibers are not arranged in a unilateral, unidirectional capacity, but they are more in a twisting fashion, so that helps to accommodate in the change in length of the nerve. Now, let's look. I'm sorry, I have a small malfunction. I will recover it right away. For some reason, my PowerPoint presentation froze, which we will get there. I apologize about that. Technology sometimes. All right. So, nerve sliding and gliding. That is also a very important attribute of the nervous tissue. Here we go again. Okay, sorry about that. Let me do it one more time, and I hope that this time will not have any problem. Okay, crossing my fingers. Let's do it. Okay, I think I will show you the slides in this capacity. So we have nerve sliding and gliding. Thank you for your patience. And that would be movement of the neural structures relative to the adjacent tissues. So I will put this slide back on, but I want to show you with my props again something. So let's suppose that this is the carpal canal, and these are the different tendons and other structures in the carpal canal, and this is your median nerve. So the median nerve movement relative to the rest of the tissue can happen in two ways. Number one, the median nerve can slide up and down, but also it can glide. If pressure is applied in a specific direction of the carpal canal, then the median nerve can glide and change position in order to accommodate that pressure. You see, in other words, I have two types of movements. I have a sliding up and down movement of the nerve, and then I have a gliding movement where the nerve will change position if there is adequate pressure on one side of the nerve. So that will help to relieve pressure from the adjacent tissues on the nerve. And finally, we have compression. Compression that can take place in the nerve because of muscles, ligaments, bony structures. You can see here, for example, if I have a muscle that is relaxed versus a muscle that is contracted, how the compression of the nerve tissue happens with the contraction of the adjacent muscle. These pictures, fantastic pictures, are taken from Michael Shacklock's book, The Clinical Neurodynamics, which I strongly recommend it. It's a great book. You can see also how various nerves can exit. This is the genitofemoral nerve that exits actually from the iliopsoas muscle, and that's why in many patients with lumbar spine pathology due to the iliopsoas dysfunction, you can have numbness and tingling in the scrotal area and the labial area because of compression of the genitofemoral nerve by the iliopsoas. So I can have various sites for nerve injury, areas of branching, fixed segments, tension points, friction sites, etc. Now, neurodynamic testing is the study of the physiology and the mechanics of the nervous system. So the basic concept states that in a normal mechanical and physiological state, the nervous system will allow pain-free movements. So when I do not have a normal mechanical or physiological state, then I have neural pathomechanics. I have a pathomechanical and a pathophysiological state. And a pathomechanical and pathophysiological state will create pain in the neural tissue. Nerves, though, are viscoelastic structures. And if they are viscoelastic structures, then they should be able to respond in mobilization techniques that take advantage of the viscoelastic properties of the nerve. So in the various techniques that we do, sequencing is very important. So I will give you a little example. Let me bring back the camera. Why sequencing is very important? Because if, let's say, for my median nerve, I initiate a wrist extension first before I do any other movement with my arm or with my neck, the greatest tension of the median nerve will develop in the area that moved first. If I place tension first in the area of the wrist, then when I complete my pattern of movement, the maximum tension will be in the area that I moved first. The opposite will happen if I move my neck first and then the rest of the movement. I add the rest of the movement. The area that I loaded first is the area where the neural tissue will have the greatest tension. So looking at the spine now, flexion will cause elongation of the entire spine by approximately 7 to 9 centimeters. Out of these 9 centimeters, the lumbar region itself will accommodate 5 centimeters. Now, another thing that is important here is that neck flexion causes cephalad gliding of the lumbar neural contents, while straight leg raise will cause a caudal gliding of the neural lumbar contents. So, and that is an important thing to say here. So let's look at that. If now I flex the neck, because in the spine I have 3 fixed segments, C5, C6 is fixed, T6 is fixed, and L4, L5 is fixed. So in this case, where I have these fixed segments, the neural contents from T6 to L45 will glide downward in a caudal direction, while the neural contents that are below L4, L5 will glide upward. This is very important because this property here, the area of the gliding, is what we utilize to classify and diagnose the specific dysfunction as a caudal dysfunction or a cephalad dysfunction. Because if there is pain, because this segment here, between T6 and L45, the neural tissue cannot glide downward, then I'm going to call that a caudal gliding dysfunction. If the neural segment below L45 cannot glide upward, then I'm going to call that a cephalad gliding dysfunction. So part of my assessment is the slump test, which many of you are familiar with. So in the slump test, I put my patient in a sitting position. I flex the cervical spine, the hands behind the back, and I apply overpressure in the cervical spine, and I assess. Then I add knee extension, and I assess. And finally, I can apply either dorsiflexion or plantar flexion of the ankle, and I assess. Now, what is the significance of the dorsiflexion and plantar flexion of the ankle joint? The significance of dorsiflexion and the plantar flexion is that dorsiflexion of the ankle is going to provide a bias towards the tibial nerve, where it will provide a greater stress on the and tension on the tibial nerve, while a plantar flexion will provide more of a tension to the peroneal nerve. So again, a little reminder, when we flex the spine, the segment between T6 to L45 is supposed to glide downward, Kodat, and the segment below L45 is supposed to fly to glide upward, cephalad. So, what will happen here? I'm sorry. And how am I going to interpret my SLUM test symptoms? If I have back symptoms only with neck flexion, without anything else, then I call that a cephalad gliding dysfunction. Because remember, the neck flexion causes a cephalad movement below L4. If I get back symptoms when I have knee extension and dorsiflexion only, then I call this a Kodat gliding dysfunction, because remember what I said, that straight leg raise causes Kodat movement in the lumbar nerves. I know this may sound a little confusing if you hear this for the first time. Hang in there, try to understand it, and when you take a chance, when you have a chance and you take one of our courses, we go through this in much more detail. If I have back symptoms with a simultaneous neck flexion and knee extension, then I call this a tension dysfunction. And of course, if I get back symptoms with neck extension and lumbar extension, then that is a compression dysfunction or spinal stenosis. I want to remind you something. You remember what I said when I started discussing about the neural tissue? That the neural tissue has three physiological properties. I said that tension is physiological, gliding and sliding is physiological, and compression is physiological. But when they do not happen properly, these physiological properties, then that becomes pathology. So when a segment is supposed to glide cephalad and it does not glide, we call this a cephalad gliding dysfunction. When a segment is supposed to glide Kodat and it does not, then we call this a Kodat gliding dysfunction, and so on and so forth. So accordingly, based on the specific now dysfunction, we provide a specific treatment. So let's suppose that I get back symptoms with neck flexion only. We call this a cephalad gliding dysfunction, right? So what am I going to do as a treatment? I will use flexion extension of the cervical spine in sitting, supine, or side-lying positions. And I can use also knee flexion extension to glide the neural tissue. This would be more the flossing type of technique that you may have heard. A similar thing, slightly different here, can happen if I have a Kodat gliding. Here, I'm going to tend to play more with the leg rather than the head. I'm going to give a little bit more emphasis to the leg because the problem was produced through the straight leg raise. That would be for a tension dysfunction. Now, for a tension dysfunction, it's going to be a little different. And I have actually a little prop that I'm going to show you. Okay, so this is a little rubber band. Imagine that in a gliding dysfunction, the treatment was the flossing technique. So if I tense the distal part, I bring close the proximal part. If I tense the proximal part, I bring closer the distal part. So this way is more of a flossing technique. If I have a tension dysfunction, I do not use flossing. What I do is I stretch. I should not be saying stretch for the neural tissue. I should say I elongate. I tense both the proximal and the distal part of the neural tissue, and then I relax it. I tense it, I relax it. I tense it, I relax it simultaneously, because that is a tension dysfunction. I'm trying to take care of a tension in this case, not a gliding or sliding dysfunction. Now, in terms of compression, which is very difficult to treat, compression is the result of most cases spinal stenosis or a space-occupying lesion, a tumor maybe. And think about this, that if you have someone who has a space-occupying lesion and they extend the neck, what is going to happen in the extension is the diameter of the spinal cord is going to increase a little bit, and as it increases, if the canal is not free, if it is stenotic because of spinal stenosis or because of a space-occupying lesion, that will produce increased symptoms. So that's something to watch. The intervention here is a little less successful. I'm going to keep on the screen for a minute, the treatment protocol that myself and my associate have developed as I'm sipping a little tea. We utilize 3 sets of 10 repetitions in each set and 3 sets at a moderate pace. If you have a gliding dysfunction, we'll use the flossing technique. If you have a tension dysfunction, we'll use the tension technique. You may have at the end of the, it is normal to have the patient feel an increase of the symptoms during the application of the technique, but those symptoms should become much less and disappear when you stop, when you end the procedure. And of course, a home exercise program is extremely important for these patients. Okay, a little picture from some of our graduates of our MCMT program. And strain, counter strain. Okay, now I have to do my little poll again of who is using strain, counter strain. So let's keep a little active and answer this real quick. Okay, everybody is answering. All right, very good. Most of you answered. I am going to close this and show you the results. So 18% of you are not using, and another 18% of you would like to learn more. So I'm going to cater to those of you who want to learn more. And as I promised, here is back my slides, because yesterday what happened, my poll slide stayed up there, but I know what I did wrong now. So here is my slide. So strain counter strain was introduced by Lawrence Jones. He was influenced by the osteopathic model, and to the contrary of Travell and Simons and other researchers in the area of myofascial pain, Jones believes that it is the muscle spindle and the primary proprioceptive endings that are the reasons of causing the somatic dysfunction and the muscle imbalances, while Travell, Simons, Levitt, Yanda, they are talking about the trigger point being the culprit of the somatic dysfunction that causes also the muscle imbalances. So there's a difference in opinion there. But let's discuss a little bit of how this works. And I am going to go back to my example. I'm going to use the example at my business associate in hands-on seminars, Mr. Rizopoulos. He likes to use this example. So look at this. Let's suppose that I am doing gardening. So if I'm doing gardening, I assume a slightly flexed position with my neck. So in this slightly flexed position, the flexor muscles of the neck, my sternocleidomastoid, my platysma muscle, they are shortened. If they are shortened, the proprioceptive firing they have is very much reduced. To the contrary, the extensor musculature is a little bit stretched, and that slight stretch of the extensor musculature provides a higher proprioceptive output. Actually, I will go back to the slides so that I can show you what I mean right here. So in this case, this would be the flexor musculature, which flexor musculature is shortened, and because of the shortening, the firing, the proprioceptive firing, will be very little to nothing, while because the extensor musculature here is more stretched, the firing is a lot more. So another thing that happens here is that because the extensor musculature is stretched, that provides via reciprocal inhibition and even further relaxation and inhibition to the flexor musculature. So when I have this relaxation of the flexor muscles, their threshold of sensitivity decreases. So those muscle spindles become much more sensitive then. If their threshold of excitation, if their threshold of sensitivity becomes so much lower because they are in this relaxed position, this means that they can become excited and they can start firing very early on. So as I'm doing my gardening now, what happens is the phone rings or somebody calls me and I have to get up like this to answer the phone. When there is a sudden movement, in other words, that happens. That can happen even when you are driving and you push the brake very fast. So in that sudden movement, what happens is the extensor muscles now, they start shortening while the neck muscles, the flexor muscles, start becoming elongated. And as they start becoming elongated, because the excitation threshold of those muscle spindles is much lower now, those muscle spindles, they start firing like crazy and they become dysfunctional. So it is this dysfunction of the muscle spindle that develops the problem according to Jones. And what he proposes is that you reset that muscle spindle. How to reset the muscle spindle? Well, what he suggests is to identify a specific tender point on the muscle. Once you find that tender point, you apply gentle pressure, and you tell the patient that this pain that he feels is pain number 5 or number 10. Then you start moving the body into a position of ease. Let me show you an example, and I'm going to come back to the slides, okay? So let's take the iliopsoas muscle, right, for lumbar spine pathology. So I will find the tender point on the muscle. Once the patient identifies that, I'm going to call the amount of the pain number 10. Then I'm going to start shortening the muscle using hip flexion, trunk flexion. I put the patient in different positions, in other words, in order to identify a position of ease that decreases that pain tenderness from level number 10 to level number 0, 1, or 2. Anything below 3, in other words. I maintain that position for 90 seconds because according to Jones, it takes 90 seconds for the muscle spindle to be reset. And then I release and I reevaluate. So this is the principle that Jones recommends. Now, in our seminars, we teach the Jones principle as well as the Leon-Chatto principle. Leon-Chatto utilizes a technique called INIT, Integrated Neuromuscular Inhibition Technique. In this technique, you locate the tender point, you apply ischemic compression on the point, then you find this position of ease, which you hold for 90 seconds. Then you apply muscle energy technique on the muscle. You apply local stretching on the tissue that surrounds the trigger point. You apply again muscle energy technique. And then you finish by taking the muscle slowly to neutral and then to a stretching position. So what is interesting about Chatto, as you can see here, is that he combines the Jones principle with the muscle energy principle and the trigger point principle. So it's a combination of techniques, and we really like this, and we do teach it in our seminars. Actually, we recently started teaching this new concept, the Leon-Chatto concept. And a few words of joint spinal mobilization. Real quickly, do you practice spinal mobilization or manipulation? I thought so. This is the subject where most people do practice it, but guess what? They need to learn a lot more. Okay, so that's important. So actually, we have in all of our courses we teach joint mobilization and manipulation, PT2, PT3, PT4, PT5, and the final course, the PT-MCMT, in our MCMT curriculum. And also Dr. Ines Nakashima in the CAMT, Certification in Advanced Manipulative Therapy. She teaches exclusively thrust manipulation. So a few words about manipulation, mobilization. So what is joint mobilization manipulation? It's a set of passive motions that have as a purpose to improve mobility and function. We have 5 grades. During grade 5, the patient has no control of the motion. They cannot stop the motion. Now, a difference that sets hands-on seminars apart than other gurus and experts in the area of manipulation of the spine is that instead of teaching one specific principle, we teach an eclectic comprehensive approach where we combine principles of all the leaders in the area. So we have identified which techniques we feel that are the most effective and most efficient, and these are the techniques that we use. So, a few principles. Principle 1, we classify the patients in 3 different categories: pain dominant, pain and stiffness dominant. If somebody is acute, they have hyperirritability, the pain is severe and it affects their sleep and their ADLs, and the intensity of the pain is more than 6, then that is a pain dominant patient. A pain and stiffness patient is a patient that is subacute with intensity 4 to 6, and a stiffness dominant patient is a patient that is more chronic, a patient that feels more restricted and the pain is less than 3. So in this case, it is very important to make this classification because the classification is one of the determinant factors as to what type of technique we are going to use. Principle number 2, we assess patients on all 3 types of possible movements. Remember that we have active physiological movements, passive physiological movements, but also we have arthrokinematic movements, or otherwise called passive accessory movements. So we assess all these movements. For example, this is a variety of active physiological movements. We may have the patient going to flexion, extension, side bending, rotation. Throughout all of these movements, we are looking at what is called the comparable sign or the joint sign. The comparable sign is basically a movement that will reproduce the patient's symptoms. We classify that as a comparable sign. While any other deviation of normal that does not reproduce the patient's symptoms, we call that a joint sign. But also we look at the restrictions, the R1, the R2, all the barriers that exist. We look at side bending, rotation, and we apply also overpressure. And then we have something called combined movements or quadrant movements. We have flexion quadrants and extension quadrants that we assess. And all these, in order to produce either comparable signs, joint signs, or to evaluate level of restriction during the movement. At the same time, we look at passive physiological movements. So we move the joints, the facet joints, in specific directions, reproducing passive movements, so that we can see which of these movements will provoke and cause symptoms. And then, after we look at that, and as I said, the point is to identify a comparable sign or a joint sign. Comparable sign is any kind of movement that will reproduce the patient's symptoms. Any other kind of deviation from normal, it's called a joint sign. Principle number 4, we have resistances, resistance R1 and R2. What is resistance R1? Resistance R1 is defined as the resistance right at the beginning of the range of motion, and resistance R2 is the resistance at the pathological barrier. Principle number 5, grades of manipulation. We have 5 grades, 1, 2, 3, 4, 5. As you can see, grade 1 and grade 2, they go only up to the first resistance of the tissue. Grade 1 with small amplitude, grade 2 with large amplitude. Grade 3 and 4 go to R2 with large or small amplitudes. And of course, grade 5 goes into the paraphysiological space. I'm going to show them to you here. Pictures speak better than words. So a grade 1 and a grade 2, grade 1 will be a small amplitude up to R1, the first resistance. Grade 2, a large amplitude to the first resistance. Grade 3, large amplitude again to R2, to the pathological barrier. Grade 4, a small amplitude. And of course, grade 5, we go down to the paraphysiological barrier. So those are the grading system that we use. It's very important also when you are deciding about what is the specific technique to use to understand the principles of coupled motion. And coupled motion can be a rather challenging to understand concept. I'm going to say a few words for it now, but probably I'm going to make another webinar discussing only coupled motions for an hour. Coupled movements are movements that occur in an unintended or unexpected direction during the execution of a specific movement. So let's suppose that you want to do side bending of the spine. If during the side bending of the spine we have also rotation, the rotation is the coupled movement. Because what you wanted to achieve was the side bending, let's say, of the cervical spine, or the side bending of the lumbar spine. That was the desired movement. But because of the mechanics of the spine, the same time that you have side bending, you also get a rotation. So the rotation is the coupled movement. So there are three important Friet's laws. Friet, an osteopath, he said that side bending from neutral position, it will produce rotation, simultaneous rotation to the opposite side. While law 2 says side bending from a non-neutral position, in other words, from a position of flexion or hyperextension, it will produce rotation to the same side. Okay, so if I have neutral position, the rotation is to the opposite side. If I have a flexed position or extended position, the rotation will be to the same side. And law 3 says that when you introduce an initial motion to a specific plane of motion, automatically that will reduce the mobility in the other two planes. What does this mean? Well, let's see an example. If I decide to produce first, the initial motion is side bending of my neck, then the rotation will be reduced, okay? While my normal rotation, the rotation from, if I just do rotation, I have this rotation of whatever, 80 degrees, 90 degrees rotation of my neck. If I first introduce side bending and then I induce rotation, the rotation is decreased because I first introduced the side bending. So that is another of Friet's laws. So Friet says then that we have two types of motions, type 1 and type 2. Type 1 is when the side bending and the rotation happens in opposite sides, while type 2 is that when the side bending and the rotation happen on the same side. So listen, there is tremendous controversy on how the coupled movements work. Okay, there's a lot of research out there that contradicts. Some of the researchers says that the whole coupled motion is totally unpredictable, but Peter Gibbons, which model I will be discussing with you tonight, and this is what we adopt in our courses, is listed here. So what this table tells you is the following, that for the segments from the T3 to the L5, if you position the spine in a flexion position, then the coupled motion is a type 2 motion, meaning a motion on the same side. So right rotation will produce right side bending. But if the position of the spine is either neutral or extension, then the coupled motion is a type 1 motion, where the rotation will produce, of the one side, right rotation, will produce a left side bending. You see the difference? So if I place someone then, a patient, in extension, and I want to produce a left side bending of the spine, all I have to do is to rotate the spine to the right from an extended position. But if I want to produce a right side bending, I can produce the right side bending if I have my patient do a right rotation from a flexed position. So you see how the flexion and the extension will cause a difference on how this works. In spinal mobilization and manipulation, though, we need to do what is called spinal locking. So let me give you an example here. If I want to produce, let's say, rotation of my neck, right? So if I produce rotation on my neck and I just do rotation from a neutral position, I will get the rotation, but my result might not be the most effective result. or my outcome might not be the best in this case. So what I need to do is to do a spinal locking. So instead of, let's say, doing just that, I may have to side bend and rotate so that I can get the greatest possible effect of my manipulative or mobilization technique. So we need to achieve spinal locking. So here is how spinal locking works. If the coupled movement is a type 1 movement, then you do your facet apposition locking, your spinal locking, by producing a type 2 movement. I know you don't remember now what type 1 and type 2 is, but here we go. So here is how it works. If I want to do a technique from, let's say, a neutral position, all right, what I know is that the coupled motion for the lumbar spine in neutral or extension is opposite side or type 1 movement, which means that my rotation and my side bending happen on the opposite side. Right rotation will produce left side bending. So if I have a type 1 normal movement here, in order to produce a spinal locking, I have to produce a type 2 movement. Example will be that my primary rotation will be to the right, which secondarily, and my secondary side bending will be to the right. This type 2 movement will create the greatest tension of a spinal locking in order for me to be able to properly mobilize or manipulate and achieve this type 1 opening of the movement. There are various techniques we can do. This technique, for example, is called the unilateral PA, unilateral posterior-anterior technique. This technique will restore rotation and side bending of the spine. Okay, so basically, I'm just showing you a few techniques. I have already surpassed the time, you know, coming to a hands-on seminars course, you can have the opportunity to not only learn the theory that you learned tonight, but also to apply all of these techniques extensively. Also, I want to mention to all of you that tonight's webinar is also recorded, and very soon it will be available in the hands-on seminars website. We hope within the next 48 hours to be able to upload it in the hands-on seminars website, so you can watch it again if you want. Also, last night's webinar will also be uploaded in the hands-on seminars website. So depending on the problem and depending on what we find in our assessment with the patient, we apply different techniques. And different techniques will restore different movements of the lumbar spine. So before I finish tonight, I would like to find out if there are any questions. I'll try to see here if anybody has a question. Yes, there are some people with questions. I have to see how I can. Okay, I see that many of you have answered a lot of the questions I asked during the all right, you're welcome. Somebody's thanking about the strain, counter strain. What determines the fixed segments? What determines the fixed segments? Those are the segments where actually there is a fixation from the dura, the spinal dura is fixed in those segments. So it is the spinal dura, the fixation of the spinal dura that produces that. Okay, so there are a couple more questions, but I can't see them, to be honest with you right now. Anyway, I would like to thank you all. What's going to happen is that when I close the webinar, within the next hour or so, you are going to receive a survey, so you can give us some feedback about the webinar. And when you give us feedback, we are going to send you back an email with your CEUs. You are receiving one CEU for today's webinar. I am also encouraging those of you who have not had the opportunity to join hands-on seminars yet to any of our programs. We have a scholarship that we give. It's a $1,000 scholarship, which is for people who want to apply. There are a couple of questions that you need to answer in the application, and we will be happy to approve you for the scholarship. You can get up to $1,000 in discounts. You can apply, not discounts actually, it's like money. You apply those $1,000 towards programs and courses. So again, I want to thank you so much for joining me tonight. A part of the questionnaire you're going to receive will be asking you if you would like other webinars like this in the future. And I hope you can email me also some topics that you would be interested in. On behalf of Hands-On Seminars, I would like to thank you all for your patience and for joining us tonight. And I will thank you, and I would like to wish you good night, good luck, and hope to see you all sometime in the future in one of our courses. And remember, try PT first. Good night.